Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Dr. Bose, welcome to Healthcare Unfiltered Express. I really appreciate you coming on, my friend.
Thank you for having me, Charlie.
It's not an easy topic, myeloproliferative neoplasms, because they're not one. Obviously, there are several of those, but there are lots of existing therapies compared to 20, 25 years ago, and there are a lot of new therapies coming on the horizon. So I've asked you to come on the show to tell us what is exciting to you as an expert in this field coming down the pike, and how would you put that in context of what's currently existing in terms of therapeutics in MPNs?
Yeah, absolutely. No, challenging topic for sure, but something really close to my heart, as you noted. And there's really been a revolution in recent years in new therapies and new paradigms for treating MPN. So let's start, for example, with the more indolent MPNs, ET and PV, which are, of course, far more prevalent than MF, right? Like a lot of the attention tends to be focused on MF. But if we can prevent MF, right, if we can intervene in the ET-PV phase and prevent MF, I think that would be better. So ET and PV, they've also seen a lot of innovation recently. So traditionally, as you know, Jadi, we've focused on reducing clots, reducing the risk of clots, and that's basically been it. We haven't had therapies that can alter the natural history, that can alter the underlying biology. So we've been sort of content with reducing clotting risk in both ET and PV. And therefore, Hydrea has been the, sort of the mainstay of treating both of those. The higher risk patients, lower risk patients are still observed, just a baby aspirin, phlebotomy in the case of PV. But all that is changing, all that is changing. And that is what really makes it exciting. We're now in the disease modification era where we have data for improved event-free survival, with an event being defined as a clot or progression to MF or acute leukemia or death. So we have data on improved event-free survival with both ruxolitinib, not so new anymore, approved for PV in 2014. But we have, relatively recent data showing improved event-free survival, molecular responses, allele burden reductions with ruxolitinib, and with ropeg interferon alpha 2b, which was approved in 2021 for PV. So in PV, I think these two drugs make me excited for a new era where we are focusing beyond clot reduction, which we are doing with both these drugs, but also, hopefully, preventing progression to MF or AML by reducing the, allele burden of the driver mutation. So I think that is very exciting. And then also, I would be remiss to not mention rusfertide. So rusfertide, not yet approved, but big news this year at ASCO plenary session. This is the hepcidin mimetic from Takeda, which is a whole different angle, and perhaps not disease modifying, but still extremely cool and very, I think, practice relevant, where you can substitute phlebotomy with a much more reliable mechanism where you're not guessing what the hematocrit is and sort of knowing to phlebotomize only when you check, but rather putting patients on this hepcidin mimetic, which functions. It's a very clever mechanism. You basically, mimic the action of hepcidin, and you deprive the bone marrow of iron, because you store all the iron in the reticuloendothelial system. So that way you ensure that your hematocrit is, consistently maintained, there's no ups and downs. So again, not disease modifying perhaps, but helps with our primary objective of controlling the hematocrit without phlebotomy. And then you have what I said about the Rux and Ropeg with the disease modification piece. So maybe in the future, we'll see combinations of these things,
Have we seen with PV and ET historically that the median survival of these patients have, are we getting close to saying that they could live a normal life with proper therapies?
Yes. So the median survival is long, as you noted. CPV and ET, in that, ET is around 20 years. Some publications say actually pretty much normal for ET. But we know that there is a risk of MF, risk of AML, risk of clots, all that. PV is a little bit worse, 14 to 19 years median. So I think you hit the nail on the head. I mean, that is the goal of this of moving away from just thrombosis reduction to disease modification and reducing the risk of MF and AML. So I think that is now, ET, not much new to say, but I'll just throw in that in ET, besides ROPEG, again at EHA this year, we heard, actually, I think ASCO and EHA, we heard about the phase 3 results from SURPASS ET. So so ROPEG could get approved for ET. But beyond that, we have bomedemstat coming. That's the LSD1 inhibitor from Merck. So disease-modifying therapy is being looked at in ET as well. And then there are several companies studying bromodomain inhibitors. So there is stuff happening in ET as well.
Yeah, great. Let's move a bit to MF. It's a bit more challenging disease with myelofibrosis. What's happening there?
So we have 4 JAK inhibitors approved in the US, 3 in the rest of the world, pacritinib being only in the US. But so in that sense, we have only one class, but then we have 4 different agents. So now I think patients have a lot more, options. They are able, you can really tailor it more to the given patient. It's not ruxolitinib for everyone anymore. Although it's a great drug, but we know it has shortcomings with cytopenias. And now with momelotinib, pacritinib, we know that people with cytopenias, where you are not able to get a good enough dose of ruxolitinib in, there you can help them by maintaining dose intensity with these less myelosuppressive agents. And while Rux is a great drug, it's a very dose-dependent drug. So if you cannot deliver it, then you don't really get that same spleen or survival benefit. So I think momelotinib, pacritinib have been a great addition. Fedratinib also deserves mention. While it is not particularly suited for cytopenic patients, it is still a great option for patients who've failed ruxolitinib and need a second-line agent, but whose counts are still preserved. So if you have somebody second-line but proliferative, and not cytopenic, I think fedratinib is a great agent. But as far as what's coming down the pike, right, that's huge. That's a massive pipeline of agents. But in general, just to stick to the themes given our shorter format today, you have combinations with JAK inhibitor that are synergistic. So laboratory-based partners with for ruxolitinib or momelotinib, for that matter, like the selinexor, which is the selective inhibitor of nuclear export, and things like nuvisertib, which is a PIM kinase inhibitor, pelabresib, the BET inhibitor. So these are one avenue of investigation. But then you also have things for anemia. We have some novel agents for anemia like elritercept from Takeda, and then DISC-0974. These are new mechanisms for anemia. Elritercept being sort of like luspatercept, but different, molecularly different. It is also an activin receptor ligand trap. DISC-0974 is an anti-hemojuvelin antibody. So drugs for anemia to partner with JAK inhibitors. And then also, we have this very exciting novel way of targeting our driver mutations in a more selective, more potent way, right? So we have mutant calreticulin antibodies from Incyte and Janssen and Janssen. We also have type 2 JAK2 inhibitors, which is completely novel. All our current JAK inhibitors are type 1. So we have a type 2 that is able to overcome resistance to the type 1s. We have mutant selective JAK inhibitors. So that's another whole class, in my opinion, where we are not going after an orthogonal pathway or some synergistic pathway, but we are going back to the driver mutation and trying to hit it more potently and selectively. And there are even other things like naftamadlin, MDM2 inhibitor. So, this huge array of drugs being looked at.
But I guess before I let you go, just listening to you, I have to ask the question. It seems that we are today no longer just aiming to improve symptoms and reducing the spleen size. These are important, still are good endpoints, but you guys are going after the disease itself. The end point, your primary goal is to go on the clone, on the molecular level. Is that what you're aiming at right now versus just kind of, I'm okay if my spleen is smaller and I feel better and I'm not anemic?
That's a fantastic question, Chadi. So you really hit the nail on the head. So spleen and symptoms and anemia to some degree have been our traditional endpoints. And we need new endpoints in the field. There's a lot of work that's going on into this, defining event-free survival, for example, progression-free survival in this context. However, I will say that from a regulatory standpoint, while it is true that we investigators are definitely shooting for the things you mentioned, I think regulatory-wise, we are still mostly using spleen symptoms and transfusion independence.
Right.
But absolutely, we want to go further than that, disease modify, and ultimately improve survival. There is actually one drug which we didn't mention, imetelstat, familiar to you from MDS, of course, which does have their primary endpoint in their phase 3 pivotal study of overall survival. But they're in the JAK failure setting. So not frontline, but in JAK failure where the survival is not good, their primary endpoint in their pivotal phase 3 is OS.
Yeah. Dr. Prithviraj Bose, thank you so much for coming on Healthcare Unfiltered Express.
Thank you so much for having me.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.